This video discusses the theory behind the layered teaching model. It has a brief description of how it is different than the current teaching model. Let's first take a quick look at our current system of teaching on a psychiatry consult service. It all begins with a phone call. Surgery has a patient who is acting crazy all of a sudden. Sounds like delirium. So a student, a resident, and an attending are assigned to the case. We have a good idea that it is delirium, but first let's do some chart review to make sure there might not be something else going on. Now to the bedside. The student starts off the interview, checking off a list of symptoms, but soon gets lost and is not sure where to go next. The resident picks up and gets the overall history as well as some cognitive assessment. The attending has a few more quick questions to fill in the gaps and build rapport before we leave. On the way back to the resident room, the resident and the attending have a quick discussion about the diagnosis and plan. Now it's back to the computer to pump out a quick note. The attending offers to do a lecture on delirium after noticing how the student struggled, but it's hard to get the whole team together that day. Instead, there's some recommended reading. And just as the article is about to be printed out, the phone or pager goes off again, another consult. Before you know it, it's the end of the rotation, which means test time for the students. Now let's look back at what does not make sense about this model. Chart review is often not very productive for students because they often don't know what they're looking for. Patient interactions are often awkward and rambling because students are so focused on the diagnosis that the process of diagnosis and the big picture is missed. After the patient interaction, there is a brief discussion that is often above the level of the student, and it is their job to keep up. We then retreat to write a note, leaving the student to do nothing. Getting a lecture after the interaction is helpful, but helpful for those who get to see a similar case again. In addition, there are others on the team that do not have a delirious patient and are distracted by other questions and thoughts while the attending is graciously trying to share knowledge. Not to mention the difficulty of getting everybody in the same room to lecture without the pager going off every few minutes and interrupting. Reading is rarely recommended or attended to on a busy service. We then often move on to the next patient without fully giving the student a chance to grasp the last one. The test confirms what the student does and does not know, but he or she doesn't have the chance at redemption when knowledge is tested as the last thing in the rotation. Ideally, we would want to know deficits prior to the end so that those gaps can be filled. Let me give you a quick analogy. In medical school education, there's a clear delineation between our teaching and experiential learning. Once a student hits the third year, there's a continued effort to teach, but with an emphasis on the experience. Again, there's a temporal delineation between these modes of learning. Attempts are often made to teach whenever possible on the wards, but our duty to patients always prevails, and teaching quickly sinks to the bottom of the priority list. This model is an attempt to incorporate these two essential modes of learning into a cohesive whole. To incorporate means to unite or work into something already existent so as to form an indistinguishable whole, to blend or combine thoroughly. So what I did is rearrange the sequence and medium with which we teach and restructured it to make learning and teaching more efficient and effective in the clinical medical training. Again, it starts with that surgery consult on delirium. In the layered teaching model, the first layer is an online lecture that can be viewed independently on the subject, in this case delirium. It is a brief introduction to the subject and gives a global view of the diagnosis with some important facts about demographics and risk factors. The video ends with a quick quiz of the material. After the less than 8-minute video, the student prints out the PDF below the video, which is a clinical map. The map gives concrete directions as to what one does in the process of diagnosing delirium. In this case, the map guides the student through a chart review and directs attention at specific information. Next stop on the map is the patient interaction, where the student is directed to look for certain signs and symptoms. It even reminds the student how to test for things like concentration. The resident and attending also play a role in that there are discussion points, questions, and items to review after seeing the patient to ensure that everyone is on the same page and the process is fully understood. Next, the map gives the student some recommended reading. The reading can be done while the resident is writing the note. Just as before, the phone is ringing again. This time, the student went through an informal patient interaction process instead of wondering why we were doing what we were doing. This makes the test really easy. The differences in the models may still seem a little obscure to you at this point, so let me highlight the differences. This is a nice graphic representation of retained information after 2 weeks. You can see how the more active a learner is, the more information that's retained. This model seeks to shift toward more active participation. The layered teaching model also utilizes a multidimensional approach to learning that seeks to incorporate every learning style and meet every adult learning theory principle. Let's go through the main components of layered teaching model and see how these theories apply. The digitalized lecture is a key component of this model in that it frees the learner from the tyranny of the classroom and the teacher. The learner can be an independent and self-motivated adult learner. It is a much more practical use of time in that teachers do not have to repetitively teach the same material rotation after rotation. Instead, the teacher has more available time to assess knowledge gaps and fill them in through discussion and questions. The flipped model also allows the learner to assess knowledge prior to when it is needed in the patient interaction instead of after the fact. The clinical map incorporates sensory, visual, and sequential styles of learning. The medical students are rarely given concrete directions. Instead, they are expected to be able to read our minds and know why we do what we do. The map takes away this opacity and enables the learner to follow along with a clear roadmap of where we are going and why. It also helps direct and focus the learner's attention and time. Most of all, it shifts the focus of the clinical care from making a diagnosis, which typically gives learners a lot of anxiety, to understanding the process of the diagnosis. Lastly, this map enables more autonomy and empowers the adult learner to take action and gain valuable life experiences earlier in their clinical rotations. Patient interactions. This is the most important part of clinical learning and always has been. But in this model, this experience is enhanced where learners are empowered to take a more active role in patient interaction instead of being an observer. In addition, they are given clear objectives through a step-by-step approach using the map to create a more relevant experience that can be reflected on later. Debriefing, reviewing, and questions. This layer incorporates reflective and intuitive styles of learning into the adult learning theory of utilizing life experiences. This tool enables collective and extroverted engagement in an action-oriented style with residents and attendings. It intelligently directs discussions and questions so that the focus is on the learner and the key concepts. Reading is always a key component of clinical education, and developing the capacity to critically read academic literature is invaluable. This layer reinforces the strongly verbal style of learning in medical education and prepares the learner for a career of lifelong learning.